Welcome back to the deep dive. Today we're jumping into a huge question, really, one that sits at the core of, well, everything from modern medicine to the entire wellness industry.
Right.
And that is, what does it actually mean to be healthy?
It sounds so simple, but it's not.
Not at all. And you sent us this incredible collection of sources. We're talking academic papers, detailed physiological breakdowns, even historical texts that really force us to look past that simple idea of just, not being sick.
That's right. And our mission today is, I'd say, pretty ambitious. We need to unpack the difference between just avoiding illness on one hand, and on the other, actually achieving a state of positive well-being. We're going to try and move from those vague wellness goals we all seem to set for ourselves every January.
Yes.
And get right into the scientific bedrock. We're talking about understanding the precise technical methods from body composition analysis all the way to the fundamental laws of adaptation that can turn exercise from just a casual activity into an effective, measurable prescription for a better life.
Okay, let's unpack this. And I think we have to start with a look back historically, because for a very, very long time, defining health was actually pretty easy, if a little pessimistic.
It was, yeah. It was defined almost entirely by what it wasn't. For centuries, health was merely the absence of a diagnosable disease, and obviously the absence of death.
You're either sick or you're not.
Exactly. And that model worked in a way because disease and mortality are, they're easily measurable. They're quantifiable. You either had tuberculosis or you didn't. Health was simply the state of not having those bad things.
But then the 20th century happens, and we see this massive leap in how long people are living thanks to sanitation, vaccines, antibiotics, all of it. And suddenly you have this huge population of people who are not sick, but they're definitely not thriving either.
Precisely. The fact that lifespans were getting so much longer, combined with this growing scientific understanding of how intertwined our lives are with everything around us, social factors, economic factors, political events, it just demanded a broader definition.
The old model just couldn't hold up.
It completely collapsed. That old binary of sick versus not sick was suddenly useless. We needed positive indicators, things that showed vitality and well-being, not just the absence of illness. And this whole intellectual shift, it really paved the way for probably the most influential and most debated definition in all of global health.
And that, of course, came from the World Health Organization.
Yes, the WHO. They formally adopted their now famous definition at the International Health Conference in New York way back in 1946.
Wow, that far back.
It was then signed by representatives from 61 member states that July, and then officially placed in the preamble of the WHO Constitution in 1948. And what's really amazing is that despite everything we've learned since, that definition remains completely unchanged today.
Okay, so let's state that definition again, because it really is the foundation for our entire discussion today. Health is, quote, a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity.
There it is.
On the surface, it sounds perfect. I mean, what's wrong with that? What were the big positive changes this brought to medicine?
Oh, the positive impact was, truly revolutionary. Yeah. First, it forced medicine to see the individual holistically.
Okay.
Not just as a collection of organs that might be failing, but as a biopsychosocial entity. That was a radical shift away from just focusing on biological problems.
And
Secondly, and this is so important for public policy, it directly highlighted what we now call the social determinants of health.
Which means we can't just chalk everything up to bad genes or, poor personal choices. We have to look at the systems around us.
Exactly. It mandates that we consider factors like your access to good housing, the safety of your neighborhood, your job security, your community.
Yeah.
All of that is just as essential to your health profile as your blood pressure is.
Okay.
And thirdly, it just elevated the whole concept of health. It moved it out of the exclusive hands of doctors and nurses and opened it up to sociologists, economists, urban planners. It made health this dynamic, comprehensive, cross-disciplinary field.
That all sounds genuinely aspirational. But reading the critiques in the source material, it seems like a whole host of problems center on one almost impossible-sounding phrase.
I know the one.
Complete well-being. How does that one little phrase cause so many problems?
It introduces this immense uncertainty. It's a measurement nightmare. What exactly defines complete well-being?
Right.
What objective standards do you have to meet? The sources argue it's basically impossible to precisely measure how healthy someone is using this definition because it's too big.
Yeah, I can see that on a personal level. If the standard is Complete well-being. Does that mean I'm technically unhealthy if I'm, say, unhappy with my job right now, even if my blood pressure is perfect and I just ran a marathon?
That is the core philosophical
Oh,
problem. You've hit it exactly. If health is this constantly evolving, all-encompassing goal, then complete well-being becomes, well, an unrealistic, almost metaphysical concept.
it sets the bar so high that maybe no one is ever truly healthy.
Not a single person anywhere. And if the goal is completely unattainable, what's the real-world consequence of that for, say, a policymaker?
I imagine it's paralysis.
It's the danger of strategic drift, or worse, political inaction. If the goal is too vague to budget for or measure against, it risks being ignored. And the critique also points out, in less developed countries where social and economic factors are so limiting, if you apply this complete standard rigorously,
Yeah.
well, you'd have to conclude that basically nobody is healthy.
Which isn't a very helpful place to start.
It's a paralyzing starting point for public health. The definition gives us this beautiful ideal, but it doesn't really give us a tool for practical measurement.
So to make it usable, we have to break it down. We have to isolate those three dimensions of well-being. How do the sources define the physical, social, and psychological parts in a way we can actually work with?
Well, when we separate them, they become much clearer. Physical well-being is the most straightforward. It's the normal, healthy function of the body,
Right.
which includes biological fitness. And crucially, the tangible capacity to actually perform the tasks of daily life, walking, lifting, whatever your body needs to do.
Then you have social well-being. That sounds a bit like external validation of your internal state.
That's a great way to put it, actually. Social well-being reflects how society views the individual. It's about performing the social roles that are expected of you, based on your position in that social structure.
So am I being a good parent, a good employee, a good neighbor, that kind of thing?
Yes. Are you meeting those expectations? It includes broader ideas like marital satisfaction, having secure employment, active social participation. If you're socially isolated or you can't participate in your expected role because of an illness, your social well-being suffers, even if your physical body is technically fine.
And the third leg of that stool is psychological well-being or mental health.
This one is all about the individual's internal machinery, their self-efficacy, so their belief in their own ability to succeed, their personal sense of contentment, and their adaptive capacity.
Yeah.
And that adaptive capacity is really key. It's your ability to adjust to a changing environment and handle the stresses that come with your social life. A healthy mind is one that can cope and adjust.
This breakdown immediately brings up that critical difference between how we feel and what a lab test might show. We have to talk about the split between objective and subjective health. Why is my own perception of my health so important, even if a doctor might disagree?
Because your self-perception drives your behavior. Subjective health is just that, your personal perception of your own physical, social, and psychological state.
Okay.
And you might have someone who feels totally vigorous and healthy, even while, lab tests show they have high blood pressure or early-stage cancer.
Yeah.
They're objectively sick, but subjectively they feel fine.
And the reverse is also true.
Exactly. Everyone might feel constantly unwell, anxious, just debilitated by all these non-specific symptoms, even when every diagnostic test comes back clean.
So in the first case, they might avoid getting a checkup because they feel fine. And in the second, they might overuse medical resources because they're convinced something is wrong.
Precisely. We have to know this self-perception because it dictates when and how people seek help. Objective health, on the other hand, is strictly verifiable. It's the absence of diseases confirmed by a physician's exam and diagnostic tests.
So the conclusion from our sources is that to be considered fully healthy, you need both.
You have to satisfy both criteria. You have to perceive yourself as healthy, that's the subjective part, and you have to be objectively healthy, so free of diagnosed disease.
But the sources dive even deeper. They suggest that this state of well-being is made up of even more non-physical elements.
Yes, an individual's well-being is like a tapestry woven from several key threads. The satisfaction you get from your daily activities, maintaining balanced nutrition, the quality of your positive relationships, having effective ways to cope with stress, because stress is inevitable, and, crucially, having a discernible purpose in your life. All of these things contribute in a major way to your perceived health, which means physical activity alone is not going to get you to that WHO ideal. And to really get our heads around the complexity of health, we first have to appreciate how our definition of its opposite disease has evolved over time.
Right.
If you look way back, the earliest explanations for getting sick were Well, they were entirely supernatural.
So disease was basically a spiritual attack. The gods were angry, or it was magic, or the evil eye. That's a tough diagnosis to treat.
Very tough. The huge historical leap forward came with Hippocrates. He's rightly called the founder of scientific medicine because he was the first person to insist on looking for causes of illness outside of supernatural powers.
So he was the first to say, hey, maybe this isn't a curse.
Exactly. He pioneered the idea that disease came from either external factors, like bad air, or from internal imbalances in what he called the four bodily humors: blood, yellow bile, black bile, and phlegm.
And that theory, even though it's, dated now, it set the stage for centuries of inquiry, eventually leading us to the very structured medical model that really took over in the 19th and early 20th centuries.
Right, and the medical model is, at its core, reductionist. It sees disease as a pathological anomaly that shows up as symptoms. Its focus is exclusively on the internal, biological, and biochemical changes: bacteria, viruses, faulty genes, accidents.
And the major criticism of that model is that it kind of treats the person like a machine, isolated from their life and their environment.
It does. It tends to isolate the person from their social context, treating them as if they're just a collection of biological dysfunctions.
But thankfully, around the middle of the last century, we started to pivot away from that purely mechanical view, which led to the much more influential biopsychosocial model.
And this is the contemporary holistic approach that really governs our thinking on health today. It came along and argued that health and disease are socially and culturally constructed,
Meaning?
meaning it demands that we consider the biological, the psychological thoughts, emotions, behaviors, and the sociocultural culture, community economics, all at the same time. It's a much more comprehensive and, frankly, realistic lens to view human illness and wellness through.
So if we put on that biopsychosocial lens, the modern influences on our health seem to break down into three big categories. Let's start with the one we can't change: heredity, or genetics.
Heredity is the set of biological traits you get at birth. It's your basic operating system. You can't change your fundamental genetic pattern, but, and this is what the sources emphasize, the capacity within that pattern can be developed or diminished by your environment and your behaviors.
So our genes load the gun.
But environment and lifestyle pull the trigger.
Exactly. Diseases that are heavily influenced by genetics include things like coronary heart disease, stroke, diabetes, some cancers, and a lot of musculoskeletal diseases. Okay, next up are the really complex environmental conditions, which range from the literal ground beneath our feet to the culture of our society.
We can break the environment down into three spheres. The physical environment includes natural conditions like climate, water quality, and the availability of green spaces, which is a critical and often overlooked part of our mental and physical health. Then there's the biological environment, which is all the living stuff: microorganisms, animals, plants. And finally, you have the sociocultural environment, which is the non-physical structure: our societal culture, its values, educational opportunities, and the devastating impact of poverty.
So it's clear these environmental factors can either protect us or make our genetic risks worse. But the third factor, behavior and lifestyle, that's the one we theoretically have the most direct control over.
It is. This covers our conscious habits like smoking, alcohol and drug use, reckless driving, poor nutrition, and of course our sport and exercise habits. And this is where the opportunity for change is just massive.
Massive.
The statistics provided are truly arresting. If healthy behaviors are consistently adopted, up to 30% of acute diseases and an astonishing 60% of chronic diseases could potentially be prevented.
60%.
That is the power of lifestyle, right there in a number.
So let's really focus in on the consequence of ignoring that third factor. Let's talk about physical inactivity. In a world where we can automate almost everything, being inactive is no longer just a neutral state, it's an active threat.
It's arguably the single greatest self-inflicted threat to our health today. And we need to be precise about what it is. Sedentary behavior, or SB, is defined as any activity that requires an energy expenditure of 1.5 METs or less.
METs being metabolic equivalent of task.
Right, and this is done while sitting or lying down. This is distinct from low-intensity physical activity, which still burns a bit more energy, say 1.6 to 2.9 METs, like very slow walking or gentle stretching.
So me watching a movie on the couch is sedentary behavior, less than 1.5 METs. But if I get up and walk to the kitchen, that little bit of movement is low-intensity activity.
Exactly, and that distinction matters, because the negative effects of true immobilization, of being truly sedentary, are systemic. They are catastrophic. The body is designed with the assumption that it will be in motion. When that stops, every major system starts to break down.
Let's start with the musculoskeletal system. How fast does the physical frame of the body start to suffer?
Frighteningly fast. Muscle strength decreases by a measurable amount every single day, somewhere between 0.7% and 1.5%, and the most significant drop happens just after the first week of complete rest.
So that 2-week vacation from the gym really does set you back.
Oh, absolutely. And what's more, due to these sustained tension imbalances in your connective tissues and muscles, you risk developing what are called contractures. These are permanent shortenings of the tissue that can severely limit a joint's range of motion and flexibility.
Wow. What about the nervous system and how we perceive pain?
Well, the neurons themselves aren't directly destroyed by being inactive, but the system suffers functionally. It leads quickly to coordination and balance problems. And for people who already have central nervous system issues, those conditions get dramatically worse.
And pain.
A fascinating detail is that sedentary people also experience an unstable autonomic nervous system, and their general pain threshold drops. This means they feel minor discomforts much more acutely. Inactivity also creates this fertile ground for psychological issues like chronic stress, depression, and anxiety.
Okay, now for the systems we absolutely rely on every second of the day. The heart, circulation, and lungs.
Inactivity is a huge tax on the cardiovascular system. It leads to an increased resting heart rate because the heart becomes less efficient. We see a risk of postural hypotension, that's the dizziness you feel when you stand up too quickly, because the body struggles to regulate blood flow against gravity.
Blood clot.
A much higher risk of thrombophlebitis, which is the formation of blood clots in the veins. A major risk for deep vein thrombosis. But most critically, your maximal oxygen consumption, your VO2 max, decreases, which severely limits your body's entire aerobic engine.
And the respiratory system pays a similar price, I'm guessing.
It does. A lack of movement reduces the strength of your intercostal, diaphragmatic, and abdominal muscles. This results in what we call mechanical insufficiency. It directly reduces how much air you can maximally inhale.
And it makes you more vulnerable to getting sick.
Yes, because it impairs mucociliary function. That's the vital mechanism that uses tiny hairs and mucus to clear pathogens and debris from your lungs. When that system slows down, you are much more vulnerable to respiratory illnesses.
Even digestion slows down without the mechanical jostling of movement.
Absolutely. The lack of that physical stimulation contributes to anorexia, gastroesophageal reflux, and severe chronic constipation. The body, from your nerves to your gut, just functions best under the rhythm of movement. Take that away, and every system pays a huge price.
This systematic breakdown makes the next piece of data even more frustrating. Even when people start to feel these symptoms, they often wait a very long time to get professional help. The sources say only about 10% of people with health problems seek medical help.
Right, it goes up to about 25% in developed countries, but it's still shockingly low. And the process of seeking help is this psychological and social minefield. When a discomfort first pops up, you enter a stage of self-assessment, asking those key questions. What happened? Why me? What if I do nothing? What should I do? And who should I ask for help?
And the most important insight there is who they ask first. And it's almost never a doctor.
Almost never. Studies show that people very rarely bypass their immediate social circle. They first talk about symptoms with family, friends, colleagues. That peer group is the first unofficial consultant. And that social barrier, that self-diagnosis phase, means critical time can be lost.
And the speed at which they finally go from talking to friends to seeing a professional depends entirely on how bad the symptoms seem, right?
Yes, the perception of danger is everything. Rapid, severe symptoms, like a sharp, acute pain or a high fever, they lead to quick intervention because the person recognizes the seriousness of it.
But the really dangerous diseases today, the chronic ones, they often start slow and quiet.
Exactly. The issues with mild, vague, or slowly progressing symptoms, the ones that don't immediately disrupt your daily life, those are the ones where a consultation is most often delayed or just completely ignored in the early stages.
That's a huge missed opportunity for early diagnosis.
It's the definition of a missed opportunity for what we call secondary prevention. The table in our source material really illustrates this bias. For something obviously alarming like chest pain, about 1 in 14 people will seek medical help. But for a chronic, recurring issue like a headache, that rate plummets to about 1 in 184. The psychological barrier denial, fear, embarrassment often outweighs the objective need for help. We rely too much on how we feel, which is unreliable, instead of on objective assessment. So once someone finally makes that commitment to get active, the vague, subjective idea of working out has to be immediately replaced with science, with objective principles. Every effective training program, whether it's for an elite athlete or for basic rehabilitation, is built on a few fundamental non-negotiable rules.
And let's start with the big one, the core mechanism of how the body adapts to anything, the overload principle.
The overload principle dictates that for any aspect of physical fitness to improve, strength, endurance, whatever, the body has to be forced to respond to a workload that is heavier or more challenging than what it's used to. You have to systematically stress the tissue, including the heart muscle, beyond its normal routine to trigger adaptation.
So we have to constantly push past our comfort zone, but there's a huge risk-reward balance there, isn't there?
Oh, a huge one. The rate at which you apply that overload is absolutely critical. Increase the load too quickly, and the risk of injury or burnout just skyrockets.
And if you go too slowly.
You get little to no progress at all. And this is compounded by the diminishing returns principle. As you get fitter, your rate of improvement slows down dramatically as you get closer to your genetic potential. The hard truth is, getting better gets harder.
And the frustration of that plateau, that leads directly into the behavioral side of things, like the diversification principle.
Yes. The main goal of diversification is to fight boredom, which is one of the biggest reasons people quit a program. Boredom leads to a loss of concentration, which leads to low performance and a higher risk of injury. The solution is carefully planned variety, changing the exercises, the location, the tools you use, or even just the session difficulty. A hard day has to be followed by an easy day.
But wait, that seems like a contradiction. If the goal is to prevent injury and stay motivated by constantly changing things up, doesn't that make it much harder to track your progress and stick to the specificity principle?
That is an excellent point. It requires a very meticulous application of the planning principle. You can't just randomly change things. Since these programs often cover months or even years, effective training needs a roadmap. You have to set short and medium-term goals that are all aligned with that long-term aim. The diversification happens within that structure, not just randomly.
And speaking of roadmaps, the individual differences principle tells us that no single plan, no matter how scientific it is going to work for everyone.
Correct. Exercise programs have to be strictly individualized. They have to be based on that person's current needs, their genetic capacity, and their unique rate of progress. Someone recovering from a knee injury needs a totally different plan than someone training for a marathon. The sources say it clearly. Not every exercise suits everyone. Individual assessment is everything.
This all ties into the specificity principle, which is maybe the most obvious, but also the most overlooked law of training.
Specificity just means you get what you train for. What you train is what gets developed, and it works on two different dimensions. The specific dimension is about targeting precise muscles. Training your triceps makes your triceps stronger.
Simple enough.
The general dimension covers the broader systemic effects, the improvements you get in your circulation, your metabolism, your heart health. And specificity also applies to the qualities you train for. If you train for muscular endurance, you don't really develop maximal strength, and vice versa.
We talked about overload or stress being the trigger for adaptation, but the actual good stuff, the structural changes, they don't happen during the workout itself. They happen later. That's the recovery and adaptation principle.
Absolutely. The training session is what stresses the tissue and nerves, but the body does the actual work, the building and repairing of stronger systems during rest. Appropriate rest periods within sessions and adequate breaks between sessions are absolutely crucial for fitness to be consolidated. Rest isn't passive, it's when you actually get stronger.
And if you ignore recovery or just stop training altogether, you get hit with the penalty, the reversibility principle.
This is the ultimate fitness penalty. The reversibility principle states that if you stop exercising or even just significantly reduce the intensity, those hard-won positive effects are lost pretty quickly. Fitness returns to its previous level.
We've all felt that after taking a couple of weeks off.
Oh yeah. That loss starts to kick in just 1 to 2 weeks after you stop. The good news is that it's a dual-sided principle. You can regain that fitness by restarting, but you have to fight your way back.
Okay, let's dive into the mechanics of this. When we talk about controlling the intensity of a workout, we manipulate 5 factors, which our sources call the 5 Rs. What are these fundamental controls?
These are the 5 variables a coach or physician can tweak to change the load on the body. First is rate or speed. Increasing your speed directly increases the intensity, especially for cardio.
Second is resistance, the load.
The applied force. Running up a steeper hill, using heavier weights, turning up the resistance on a bike.
Third, repetitions, the volume.
Yep, the number of reps or sets. More reps means more total work is done, which stimulates more adaptation and endurance.
Fourth is range of motion, or ROM, how far you move.
The joint movement angle. Since energy is just force times distance, increasing the distance you move, a weight significantly increases the energy you expend. This is also really crucial for effective flexibility work.
And the last one is rests, the breaks.
The rest time between sets. Shorter breaks increase the intensity of the workout. For strength work, rests are usually kept pretty short, 2 to 3 minutes max, to stop the muscles from cooling down. Decreasing your rest time is a great, subtle way to boost intensity without just adding more weight.
These measurable variables lead us right into quantitative fitness assessment. To treat exercise like a science, we need numbers. And the first, and often most motivating one, is body composition.
The big goal here is to figure out a person's ideal body weight. But to do that, you first have to accurately determine their body fat percentage. And the methods for doing that vary a lot in terms of accuracy and accessibility.
So at the top end, the research-grade stuff, you have things like underwater weighing, CT scans, MRI, DEXA scans, gold standards, but totally impractical for everyday use.
Exactly. For commercial use, you often see those bioelectrical impedance machines, which are affordable but, notoriously less accurate because they're so sensitive to your hydration levels. So for field use in sports, the most common practical method is still using skin fold calipers. And this method works because about 50% of your total body fat is stored right under the skin.
Subcutaneous fat.
Right. When it's done correctly and consistently, skin fold measurements are a surprisingly reliable estimator with a typical accuracy error of less than 3%.
But it's not just about the percentage of fat, it's about where that fat is located. That's why we measure waist circumference and the waist-hip ratio.
Yes, waist circumference is an immediate red flag for obesity-related risk, especially for cardiovascular disease and diabetes. For women, a measurement of 90 to 109 centimeters is high risk, and anything over 110 is very high risk. For men, the high-risk band is 100 to 120 centimeters, and over 120 is very high risk.
And the waist-hip ratio?
Also critical. A ratio greater than 1.0 for men and greater than 0.85 for women indicates a high health risk because of that central fat distribution pattern.
The sources then take us through this really complex calculation to determine ideal body weight. We don't need to do the math live, but can you explain the significance of this? How do they turn a simple skin pinch into a precise, objective number?
Well, the precision is everything. They use multi-site skin fold measurements, often 3 or 7 specific spots on the body, and they plug those numbers, along with the person's age, into these very specific complex formulas, like the Johnson 1990 equations, to determine the person's body density.
So body density is the key input.
It is. Once you have that really accurate body density number, you use the widely accepted Siri equation to translate that density into a percentage of body fat. The key takeaway is that this formula transforms a subjective physical measurement, a caliper pinch, into an objective measure of fat mass.
And let's run the result of the example given. We have a man who weighs 90 kilograms and has 25% body fat. What does this scientific calculation tell him about his weight goals?
The calculation reveals that his ideal body weight should be about 79.4 kilograms, assuming he maintains a healthy muscle mass. So this tells him, specifically, that he's carrying 10.6 kilograms of excess fat that needs to be reduced. And that precision is the difference between a vague, I want to lose weight, and a targeted exercise prescription.
Beyond body composition, the second critical pillar is cardiovascular endurance. How do we measure the capacity of the heart and lungs out in the field?
We start with the basics. Blood pressure. A healthy reading is a systolic pressure, that's the contraction pressure of less than 120, and a diastolic or relaxation pressure of less than 80. And we have to remember, blood pressure naturally goes up with age and height, and it fluctuates all day with exercise, emotions, stress.
Okay, so for field-based tests of true aerobic endurance, what are the common standards?
The simplest are the 6 or 12-minute run-walk tests, where we just measure the total distance you can cover on a flat course. It's a great proxy for how much work your heart and lungs can sustain.
And what about something more structured?
A more structured, time-honored test is the Harvard Step Test. You climb a 45-centimeter step for 5 minutes at a fixed rhythm of 30 steps per minute.
Right.
And then we calculate what's called the Physical Efficiency Index, based on how quickly your heart rate recovers in the first 3 minutes after you stop. A fast, low-rate recovery indicates a highly efficient heart.
And finally, there's a useful metric for gauging the heart's actual workload called the Barak Index.
Yes, the Barak Index calculates the heart's energy index. It's the sum of the systolic and diastolic pressure, multiplied by the heart rate, and then divided by 100. For a healthy person at rest, That score should be between 110 and 160. A score over 200 suggests a hypertensive tendency, while below 90 suggests hypotension. It's a useful, quick way to quantify your circulatory effort and risk. So with the assessment done and the principles established, we can finally move into the actual modes of training. Let's start with aerobic exercise, literally air using life. This is the foundation of cardiovascular health.
And the sources define aerobic exercise by a very specific and necessary intensity range. It's not just any movement.
No, it's a sweet spot. Aerobic activity has to be intense enough to significantly increase your oxygen consumption and breathing speed, pushing you above a lower threshold, which is typically around MET5.
But not too intense.
Right. It can't be so intense that it prevents a sufficient oxygen supply to the muscle, so it has to stay below that upper threshold, generally around MET9 or 10. The optimal duration for this sustained effort is somewhere between 20 and 45 minutes without reaching total physical exhaustion.
And what are the principles for prescribing it and the major benefits that make it so non-negotiable?
Well, aerobic training is medium intensity, long duration, a minimum of 15 sustained minutes. The primary way you control the intensity is by using a target heart rate, and the physiological effects are profound. It improves muscle endurance, it accelerates aerobic metabolism, which increases the use of fats for fuel.
Good for weight loss.
Very good. It also increases blood circulation through the growth of new capillaries, what's called neovascularization. It increases your red blood cell count for better oxygen transfer, it lowers your blood pressure, and it strengthens and enlarges the heart muscle itself, which is what lowers that vital resting heart rate.
And beyond all the physical plumbing, the mental boost is often the thing that keeps people coming back for more.
Absolutely. Regular aerobic exercise significantly reduces stress levels and is a powerful tool for lowering the risk of depression and anxiety. It stabilizes your mood and increases your adaptive capacity.
Let's look at some common examples and their metabolic costs, their METs.
Walking is the most accessible. A slow pace of 4 kilometers an hour is about 3.0 METs, while a very brisk pace of 6.5 kilometers an hour jumps up to 5.0 METs.
And then there are specialized versions.
Right, like Nordic walking using poles. That works the upper body, so it results in about 40% more METs than regular walking, often with the same perceived effort. Then you have backpacking, or military-style walking with a load, which has very high MET values and builds muscular endurance very efficiently.
How do cycling and swimming compare?
Cycling has a huge range. A comfortable cruise below 15 kilometers per hour is about 4.0 METs, but a serious racing tempo can be a very high 12.0 METs. Swimming is generally excellent, anywhere from 5.0 to 10.0 METs.
Any cautions with swimming?
A key note of caution for people with cardiac risk is that swimming can intensely overwork the smaller muscles of the upper body, so it needs careful monitoring. For people with joint problems, water exercises or aquarobics offer a lower intensity, usually around 5 METs, with much less impact.
And a quick clarification on fast and cardio. Why is exercising on an empty stomach sometimes used in anti-obesity programs?
The theory is that it may speed up fat resolution because it mobilizes more glucose and fatty acids into the blood for immediate use, which can also help curb appetite later. It can be an effective technique, but the caution is critical. Any feeling of powerlessness or extreme fatigue shouldn't be allowed to compromise the necessary exercise intensity or duration.
Okay, shifting gears now from that long, steady effort to the short, explosive work. Anaerobic exercise. This uses a completely different energy system.
It does. Anaerobic exercise is high intensity and short term. Its primary goal is to develop your type Ti-X and type Ib, or fast-twitch muscle fibers. And the key metabolic bonus is that developing these fibers means they consume more energy even when your body is at rest. A powerful tool for weight management.
And how is this kind of high-intensity work structured, since the body obviously can't sustain it for long?
It relies almost entirely on the interval method, alternating these high-intensity bursts with periods of rest or low-intensity recovery. Really short, explosive exercises like 2 to 5 seconds can be incorporated into aerobic sessions. But exercise is limited by lactic acid buildup, which is anything lasting less than a minute or two, should use interval training exclusively to manage that fatigue.
What are the unique benefits of pushing the body past its aerobic limit like that, just temporarily?
Anaerobic training has really powerful rapid effects. It significantly raises your fatigue threshold, so your muscles can resist sudden exhaustion for longer. It shortens your recovery time by speeding up the clearance of waste products like lactic acid. And critically, it elevates your basal metabolic rate for a prolonged period. We're talking 12 to 18 hours after the session.
So you're still burning calories at a higher rate long after you start.
Exactly, a powerful anti-obesity tool. But the safety warnings here have to be taken very seriously.
Who is this for and who is it not for?
Anaerobic training is strictly recommended only for highly fit individuals. It is definitively contraindicated for new exercisers, pregnant individuals, or anyone with pre-existing medical conditions, especially cardiac issues. And even if you are fit, you have to ease into it. Start at 60 to 70% of your max intensity before you ever think about reaching that 95% plus range. And the sessions have to be short, 30 to 40 minutes maximum.
Next up, let's talk about strength training. This is goal-directed work to increase strength, endurance, tone, size, and shape of specific muscles.
And the progression of strength gain is really remarkable. It follows 3 distinct phases over about 6 to 12 months for a responsive person. And this helps explain why people often feel stronger long before they look bigger.
So what's happening in that first phase, the first 2 or 3 months?
That's the neural phase. During this time, the muscle size itself doesn't really change much. No immediate hypertrophy. The strength increase comes from the nervous system becoming more efficient. It improves motor neuron activation, which lets the brain recruit and engage more muscle fibers at the same time. The wiring gets better before the muscle gets bigger.
Then we get to the phase where you see the visible change.
Right. The second phase is the hypertrophy phase. This is where actual muscle mass increases because the muscle fibers thicken. This is the bulk building stage. And then finally, after 6 to 12 months, you enter the compositional phase, which is marked by changes in how the muscle fiber types are used. Overall strength can increase by 50 to 100% in this optimal window.
We have 4 major categories of strength training movements defined by how the joint and muscle respond. Let's start with the most common, dynamic or isotonic exercise.
Dynamic exercise is your classic weight training model. The joint angles and muscle lengths change as the muscle contracts. The resistance can be constant, like with a free weight, or variable, like with elastic bands. Because you're applying force through the whole range of motion, this is generally seen as the most effective method for overall strength gain.
Now, static or isometric exercise is completely different because there's no movement at all.
Correct. With static exercise, the joint angles and muscle lengths stay constant. The range of motion is 0. You're holding a posture or pushing against something that won't move. It is very effective for increasing your maximal force at that specific joint angle. But, and this is critical, it does not build endurance.
But it has a specific use case, right?
Yes, because it raises your heart rate and blood pressure significantly less than dynamic exercise. It's the preferred, safer method for high cardiac risk patients who still need strength maintenance.
And then there's the high-performance modality, isokinetic training.
Think of isokinetic training as using a smart machine that knows exactly when your muscle is strongest and adjusts the weight mid-lift, forcing you to maintain maximum effort at every single angle. It requires specialized machinery where resistance is applied while the joint moves at a fixed, constant speed. Because the resistance perfectly matches the muscle's capacity through the whole movement, it is the most effective method for pure strength gain, and it's favored by elite athletes.
And finally, the one that requires the most caution, eccentric exercise.
This is where the muscle lengthens while it's actively under resistance, like when you're slowly lowering a very heavy dumbbell. This action produces extremely high force, in some muscles up to 3 times their maximal contraction force. The risk of injury is very high for the unfit. It should only be used by advanced athletes, often as part of plyometric training.
Moving from strength to movement quality, let's talk about flexibility, which we achieve through stretching. A healthy muscle should be able to stretch about 1.6 times its normal length.
And the benefits of maintaining that flexibility are enormous and very practical. It makes routine daily activities easier, it improves your range of motion, which enhances stability and balance, and that's crucial for reducing falls in the elderly. It increases blood flow for faster healing, improves posture to reduce chronic pain, reduces stress, and helps prevent common muscle injuries.
But there are crucial safety protocols for stretching that have to be followed to avoid doing more harm than good.
First, stretching must always be performed after a proper warm-up, ideally 10 to 15 minutes, or after your aerobic activity when your tissues are warm and pliable. The protocol is to hold the stretch slowly for 10 to 30 seconds, repeating it 3 to 5 times per session. You must never cause pain, and fast or jerky ballistic movements can cause muscle microtrauma and should be strictly avoided.
And what about those surprising performance trade-offs? Doesn't being too flexible actually hurt some athletes?
It does. This is a fascinating nuance. Excessive flexibility can reduce performance in sports that require mechanical stiffness, like running, where less flexible runners have actually been reported to be more metabolically efficient.
Wow.
Furthermore, doing a lot of static stretching before a high-power activity has been clearly shown to reduce your maximum power output for more than an hour after you finish stretching. So timing is everything.
Okay, finally, let's wrap up with the essential components of motor fitness. Everything required for seamless, responsive movement. Agility, balance, coordination, reaction time, and speed.
Agility is defined as the ability to change your body's direction suddenly without losing your balance. Training involves two types of drills, those with pre-planned directional changes like cone drills,
Mm.
and the more advanced cognitive component, which is called reactive agility training. This forces you to make quick, adaptive decisions based on cues from your environment, like an opponent's movement or a moving ball.
Speed, on the other hand, seems to have a pretty hard biological limit.
That's true. Speed is highly related to genetics. It relies heavily on your type 2 or fast-twitch muscle fibers. While dedicated training can improve your speed, the potential gain is limited, usually to around 15 to 20%. Genetics really does set the ceiling for your maximal speed.
And what about improving reaction time? That feels like something that's highly trainable.
It is. Reaction time training focuses on speeding up how you process cues. The drills emphasize rapid processing of visual or auditory signals. Things like catching dropped balls, reacting instantly to a verbal command with your eyes closed, or identifying and reacting only to a specific color among multiple dropped objects. These drills force your nervous system to process input and initiate motor output much faster than usual.
So we have covered a remarkable amount of ground today. We started with that lofty, sometimes abstract definition of complete physical, mental, and social well-being from the WHO.
Right, which forced us to view the individual holistically.
And then we dove straight into the tangible, catastrophic physics of why we have to move, detailing the specific systemic harm that immobilization causes to our muscles, our heart, our lungs.
And we learned that achieving fitness isn't just about vague effort, it's about applied science. Gains are governed by those non-negotiable principles we discussed: overload, specificity, reversibility, and the precise, measurable control we get from the 5 Rs. Moving from casual activity to real, goal-directed fitness means adopting a measurable, individualized prescription.
And we shouldn't forget that balanced nutrition and careful hygiene are truly equal, necessary partners to exercise and achieving that overall picture of health.
Indeed. Now, let's bring all this scientific detail back to the behavioral world we live in. We spent some time exploring the fact that for those slow-onset issues, people often rely on self-assessment and their social circles, their friends and family, before they ever see an expert. The psychological barrier to getting help for chronic issues is high, and it leads to delayed diagnosis.
So, here is the provocative thought for you to carry forward from this deep dive. Given that early diagnosis is essential for what we call secondary prevention, yet we know most people bypass the clinic and rely on their social environment for that initial consultation. How can we best leverage that social environment factor, the very component the WHO defined as key to health, to push individuals toward objective evaluation faster? The resources needed to truly improve early detection for those chronic, slow-onset issues might not be found inside the walls of the hospital or the gym, but rather by strategically activating the accountability and support networks within the community itself. Think about that the next time a friend or relative tells you about a mild but persistent ache.